Good afternoon, everybody. Thank you for joining us here at lunch. Welcome to today's knowledge mobilization rounds on delirium, everything you needed to know. And we're just delighted to welcome Dr. Samuel Thrall from McMaster University in the Niagara Health region. I'm Dr. Alexandra Papaioannou. I'm the chair of the Regional Geriatric Program Central, director of the GERAS Center for Aging Research at Hamilton Health Sciences, and a professor, Department of Medicine at McMaster. We're really delighted to celebrate with you. We have over 400 attendees registered. I know there's probably more. For instance, my trainees are residents. There's 5 of them in the room with the nursing staff. World Delirium Day is happening March the 12th. This is a global endeavor to raise awareness on delirium. It's a serious but often overlooked condition. It affects many hospitalized patients, particularly older adults. Today's session will help you recognize delirium quickly, confidently, prevent hospital-associated delirium with non-medication strategies, and understand the multi-component approach to delirium prevention. Dr. Sam Thrall is a geriatrician at Niagara Health. He's an assistant professor in the Division of Geriatric Medicine at McMaster University's Niagara Regional Campus. His passion lies in promoting and implementing evidence-based, age-friendly practices through education and quality improvement. He serves as the co-chair of the Older Person Strategy at Niagara Health and is the director for quality improvement at McMaster University for geriatric residents. So welcome, Sam. And I'm just going to say we've been consulting at the Juravinski all week. Very common question from the hospitalist. Why is the patient still delirious? Is there anything we're missing? And from the family's point of view, what's happened? Why are they not back to the same person that they were when they came to hospital? So we're really delighted, and I'm going to turn it over to Dr. Thrall.
Thank you so much, Alex. Thank you for the introduction. Thank you, everyone, for attending. It's such a pleasure to be with you. As Alex said, we are clinician educators, and I just came from seeing a delirious patient in the hospital here just now. So this feels like a pertinent topic for us, and I hope this time is useful to you today. I'm going to share my screen. I have some slides to help guide our conversation, and there will be a time for Q&A at the end. Alex, yeah.
Sorry, I did miss some housekeeping. Sorry, Sam. As people log on, just to let you know, the session is being recorded. It's going to be available on the GERAS YouTube channel. I'm going to tell you that I've listened to Sam speak before, and I love listening to it again and again. You'll hear different pearls, so I encourage you to share it with your teams. Your question and answer at the bottom function. You can submit questions during the presentation. We'll address them at the end. And this webinar qualifies as self-approved learning under the Royal College of Physicians and Surgeons MOCOP program.
Outstanding. So we heard our learning objectives already. Let's start with a case to kind of anchor our conversation. And so this is a case from my own outpatient practice and a patient that I've seen. So this is a 75-year-old woman who comes to the hospital from home. She lives at home alone. She has a previous diagnosis of mild cognitive impairment, atrial fibrillation, and some cardiovascular risk factors. All of these chronic conditions are managed on appropriate medications. At baseline, she's independent for all of her basic and instrumental activities of daily living, but has had 3 years of short-term memory decline with a MoCA of 20 out of 30. She presents to hospital with fever, mid-back pain, and generalized weakness, and her initial workup demonstrates anemia, an acute kidney injury, and a urine culture that's positive, all of which are appropriately managed by her care team. In hospital, she was restless, couldn't remember her close family members' names, didn't recognize her surroundings, and thought that there were pregnant women in her house. She couldn't express her thoughts completely. A well-meaning member of the health care team told the daughter, "Your mom has severe dementia." And the daughter responded, "This is not my mom." So we use that as a launching point. So delirium, what is it? Delirium is a sudden change, typically over hours to days, in an individual's cognition or behavior. It has a fluctuating course. There's clear periods and less clear periods. It's always associated with a change in attention or awareness. And so we often do a disservice on our bedside assessments when we only comment on orientation, when in fact we should be commenting on a patient's attention if we're concerned about delirium. We'll get into that in just a moment. It's not due to another neurocognitive disorder. Basically, what this is saying is that you can have delirium superimposed on top of another cognitive disorder, like mild cognitive impairment or dementia, and it's always due to an underlying physiological disturbance or a medical condition. And so delirium doesn't get triggered on its own, and usually a change of an environment is not sufficient in and of itself to set off delirium. So if we can boil it down, what are the ABCs of delirium? It's an acute change in behavior or cognition, always, always affecting attention. I want you to take this message away from this talk. Delirium is a medical emergency. It's the third most common harmful event experienced by individuals in Canadian hospitals after urinary tract infections and electrolyte disturbances. When we look at patients who have had an episode of delirium and compare them to age and comorbidity match controls, over the next 2 years, they're at higher risk of dying, they're at higher risk of long-term care placement, and they have a 12 times increased risk of developing dementia over the 2-year period after their first episode of delirium. It's also associated with longer stays in hospital. Delirium is extremely common. As many as 50% of individuals 65 years of age and older can experience delirium during their hospital stay. It's highly unrecognized. We miss 2/3 of cases of delirium in our documentation. So it is not picked up or acknowledged very often. And this is another one of those key messages I don't want you to miss from this talk. 30 to 40% of hospital-acquired delirium is preventable with early non-medication strategies. What makes someone at risk of developing delirium? Well, it's this balance of what we call predisposing factors, who the patients are before they ever come into the hospital, and precipitating factors, those things that can occur which lead to hospitalization, or those things which occur within the hospital stay. So some of the things that mount on the predisposing side of that, this figure, are things like cognitive impairment, age, sensory impairment, polypharmacy, multicomplexity, all those sorts of things. The more predisposing factors you have at baseline means that you need a less noxious stimulus to tip you over or to precipitate a delirium. And this is why we see older individuals who are frail, who have cognitive impairment and polypharmacy, suddenly become delirious with an episode of dehydration or constipation or a small medication adjustment. There's a whole list that we could go through in detail, but these would be some of the most common things we see: older age, underlying cognitive impairment, a history of delirium, substance misuse. Hip fracture patients are notorious for developing delirium in hospital or any other critical or severe illness. I'm coming back to that message I put before you a bit earlier, which is 30 to 40% of hospital-acquired delirium is preventable with non-medication strategies. We've known this for 25 years, 26 years now, actually. Sharon Inouye published her landmark New England Journal paper in 1999 on the Hospital Elder Life Program. This is what it is, and this is what it boils down to. Modifying these 6 risk factors in hospital with early intervention prevents 30 to 40% of hospital-acquired delirium. Number needed to treat of 17. This is validated across care settings all over, ICU, Emerge, everywhere. What are these 6 risk factors that we try and optimize? keeping the mind engaged. We have to stimulate the mind using various things. That could be socialization, that could be mind puzzles, conversation. We want to make sure that people have access to windows during the and natural sunlight during the daytime, all those sorts of things. We want to keep people moving. The study showed had people moving 3 times a day. It's not sufficient to get out of bed once a day. We need to get people moving on a regular basis in hospital. We want them sleeping well. Can we minimize interventions that are disturbed sleep that are unnecessary? Do we need to check the vital signs at 11 p.m. if the patient's perfectly stable? Do we need to poke them at 2 in the morning unless, if it's not urgent or it's not stat blood work? In the study, they even went so far as to provide patients with warm glasses of milk and back rubs to help them sleep. Maybe not realistic in our care settings, but this is what was in the study package. We want to optimize their sensory function, seeing and hearing, making sure people have their glasses who need them, have their hearing aids who need them. Maybe we need to use a pocket talker to help communicate better with them. And then finally, addressing nutritional status. It pains me every time I walk into the room in a hospital when patients' meal trays are just sitting there cold because no one's taken the time to open them, or there isn't access to, some a water if the patient's not fluid restricted. And so again, the message on this stuff is the small stuff pays. We have to pay attention to these little things, and it's all of our responsibility. Now, in the study, they delegated this to an army of volunteers. Not every hospital has that capability. And so, what do we do when frontline nursing staff are just completely overwhelmed? Physicians can't attend to this. Who owns this? Well, what's amazing right now is more and more evidence is coming out that families can own this. And so we have to empower our families who are sitting at the bedside. They want to be there, they want to be involved in some cases. Let's empower them to implement these help strategies to help prevent hospital acquired delirium. Okay, we're going to shift gears here and talk about how we identify delirium. In 2025, we still do not have a biomarker diagnosis of delirium. So I can't order a blood test or a scan or an EEG that's going to diagnose delirium. It is a clinical diagnosis. And for better or for worse, the gold standard for delirium diagnosis continues to be the DSM-5. I don't carry around a copy of the DSM-5. I would not expect you to memorize the DSM-5. So we use useful bedside tools as a surrogate to help identify delirium. I propose using 2 different tools. Maybe you've heard of these, maybe you haven't. Put these in your back pocket. They have great testing parameters compared to the DSM-5 gold standard. The first one I'm going to put before you is the ultra brief 2-item questionnaire. 2 questions. Please tell me the day of the week. Today is Wednesday. Please tell me the months of the year backwards, starting with December. If they answer both of these questions correctly, you can confidently rule out delirium with a 94% sensitivity. Unfortunately, if you get one or both of these questions wrong, it doesn't tell you if the patient has delirium, so the specificity is not very good. But in about 40 seconds, you can rule out delirium at the bedside quite confidently if they answer both of these questions correctly. That's the UB2. The best test, bar none, to rule in or to rule out delirium is the CAM, the Confusion Assessment Method. At our institution, it's standard of care that the CAM should be done every shift that a nurse is on. And so that means a patient should have the CAM done twice a day if they're at risk of delirium. I use a mnemonic device to help me remember the 4 core CAM criteria, and I use another geriatric acronym to help me remember it. IADL, like instrumental activity of daily living. The I stands for inattention. A, acute and fluctuating. D, disorganized thinking. And L, level of consciousness, which is altered. To be CAM positive, you have to have the I and the A and one of either the D or the L. Okay? The CAM has excellent sensitivity and specificity. It helps you confidently rule in and rule out delirium, about 95% for both. That's the mechanics. How do we use it? Well, if you used your UB2, you've already done your question of attention. By asking someone the months of the year backwards, that's a formal test of attention at the bedside. And so you've actually already done that, and you may or may not know whether you would know whether they're attentive or not. Other tests of attention that you could use at the bedside: days of the week backwards, repeating a 5-digit span in the same order, spelling world backwards, serial sevens. These are all formal tests of attention, and I recommend that attention should be tested formally at the bedside. Acute and fluctuating. This is where the CAM sort of breaks down and becomes a bit less useful. You have to get collateral history to assess where the person is today as compared to their baseline. It's one question. Is this individual more confused than their usual self? If the answer is affirmative, then there's been an acute change. Fluctuations are a little bit easier to observe at the bedside. If sometimes people will fluctuate right in the room with you. I always tell my students, it's never normal for someone to fall asleep in front of you mid-conversation. That's not normal. They're fluctuating. You might see it over the course of a shift or 6 or 8 hours, right? Where there's clear periods and less clear periods. So you need ancillary information. You need corroborative information to answer that question about, is this person acute and fluctuating? Disorganized thinking. These individuals tend to be unclear, illogical, rambling, tangential. This is where that disorientation piece might actually fit in. Where, like our patient this morning, they thought they were in their living room. Many patients will say, I'm on a cruise ship, right? That's where that fits under the disorganized thinking. If you have an older individual in hospital who develops new psychosis, meaning new hallucinations or delusions, the top of the differential diagnosis is delirium until proven otherwise. Less likely to be things like Lewy body disease or late life schizophrenia. I want you to think delirium, delirium, delirium until proven otherwise. Finally, altered level of consciousness. There's 3 main phenotypes. There's the hyperactive phenotype, hypervigilant, on edge, pulling at tubes, trying to get the IV line out, restless, climbing out of bed. There's the hypoactive phenotype, sleepy, drowsy, difficult to rouse. These are the patients who decondition really quickly. They become incontinent and immobile. And then there's the mix. They flip from one to the other. The important pearl here is that 75% of all deliriums are hypoactive. Nobody ever misses the hyperactive deliriums, but you have to have a high index of suspicion for the hypoactive deliriums. They're easily missed. They never give you any trouble, but they lie there in decondition and they're sleepy, drowsy all throughout the day. That's how you use the CAM. This is my number one go-to. I propose using a 2-step screening assessment for delirium. Start with your UB2, 40 seconds. You might be able to quickly rule it out with 2 positive or correct answers. And then if you're not sure, go on to the CAM and complete the assessment to help you rule it in definitively. We've covered delirium as a medical emergency. We've covered prevention. We've covered identification. Now we're going to proceed to management. Again, in 2025, we do not have pharmacologic therapy to treat delirium in and of itself. The treatment of delirium is identify the problem that caused it and treat that problem, and we hope that the delirium starts to clear after that. I propose a 4-prong approach. It's multi-component. We need the whole interprofessional team working together to deliver on this. So what we do, first and foremost, identify and treat reversible causes. We'll get into this in a little bit more detail. We have to address behaviors, either using non-medication or medication strategies. Third, we have to anticipate and prevent the complications of being in hospital: urinary incontinence, immobility, falls, pressure injuries, and so on. And then we need our interprofessional colleagues. I'm a physician by training, and so I need all my colleagues from all different disciplines to help restore function. How do we recondition them cognitively? How do we get them back to moving or building strength in their mobility? How do we ensure that they're able to return to performing their activities of daily living? Let's talk about a workup for delirium. So this is the question of identifying and treating those causes which may be contributing. There's a myth in delirium care that it's one precipitant causing the problem. I submit to you that delirium is always multifactorial. It always has many precipitants contributing. And so we need to do a thorough investigation for precipitating causes. I propose using the acronym DIMS: drugs, infection, metabolic causes, and structural, just as a systematic way to help you think through in a comprehensive fashion What are the precipitating causes of delirium in your individuals, in the people you're caring for? So what are the most common medications that we see precipitating delirium? Sedative hypnotics. Benzodiazepines are notorious for causing delirium, number needed to harm of 6. Remember, zopiclone or other Z drugs are just as harmful as it pertains to delirium as the benzodiazepines. They're no better. Opioids, notorious for causing delirium. Anticholinergic medications, things like Benadryl, Gravol, but also tricyclic antidepressants, antimuscarinic bladder agents like tolterodine, fesoterodine, solifenacin, those sorts of things. And also remember withdrawal syndrome, particularly alcohol withdrawal as an example. When it comes to infection, everyone remembers the UTI. Some people even go so far as to associate UTIs with delirium. I want to break down that myth. I want you to maintain a broad differential diagnosis when you think about infections precipitating delirium. Any infection can do it. Skin and soft tissue infections, pneumonia, so on and so forth. My one little point here is that rarely, although it can occur, rarely is meningoencephalitis the precipitant for delirium. Of course, we've had situations like that. You can think of a case of West Nile virus encephalitis we had last summer. So it does come up, but generally not part of your first pass investigations. Metabolic causes, most common ones: anemia, hyponatremia, hypercalcemia, acute kidney injuries. Any thyroid abnormality can do it: hyperthyroid or hypothyroid, vitamin B12 deficiency. If you've ever had a geriatric consult, you know you're always going to order a TSH. You're always going to order a B12. And so I propose that you include those in your first pass investigations before you ask a geriatrician to come and consult on the patient. My cutoff, and everyone practices a little bit differently, but I use a cutoff of 350 for vitamin B12 deficiency. The point here is that the lab reference ranges are not accurate in assessing vitamin B12 deficiency. We might debate whether it should be 300 or whether it should be 400. I split the difference on 350, and we can argue about that. But just know that a normal B12 on the lab reference ranges is not accurate. So use a higher value. I argue for 350. Structural causes. Think about things outside the brain and things inside the brain. So when we think about things inside the brain, we think about things like stroke precipitating delirium, intracranial hemorrhages, particularly patients with a fall who might be on anticoagulant. When we think of structural causes outside the brain, that could be anything: a myocardial infarction, a GI bleed, so on and so forth. But there's 2 things I never want you to miss. They're easily treatable, easily reversible, but they go unnoticed unless you think about it: constipation, urinary retention. Very, very low hanging fruit for delirium. What do the Choosing Wisely guidelines say about brain imaging in delirium? Choosing Wisely says, do not routinely order CT scans of the head in hospitalized patients with delirium unless they have focal neurological findings, they've had a fall with head trauma, there's concern for fever with meningoencephalitis, or there's unexplained decreased level of consciousness. Now, I'm a consultant geriatrician. I have a referral bias. I'm usually getting involved when the delirium's not getting better or there's been no precipitant identified. Basically, every patient I see gets a CT head, but it may not be part of your first pass investigations. So that's how you identify and hopefully treat the multifactorial precipitating causes of delirium. Now I want to speak to addressing behaviors in delirium. The first line treatment for addressing behaviors in delirium is always non-pharmacologic strategies. We really have to take the default posture. Our modus operandi has to be medications are a last resort. I'll talk about medications in just a minute, but by way of reminder, get your patients up and moving. Use social restraints like their care partners. Use the GPA course, the gentle persuasive approaches methods. Use validation in affirming what they're feeling. Use various orienting stimuli and make sure their senses are optimized. I put this because I feel strongly about it. Physical restraints are a never event. I recognize there's all sorts of caveats and situations where physical restraints may need to be used for the safety of staff or the patients. Those aren't the situations I'm talking about. What I'm trying to get with this point here is to say, we resort to using physical restraints a little too quickly in some care settings. Again, healthcare is very localized, but I'm specifically speaking to those areas where we see physical restraints used for all sorts of minimal issues, grumbling issues, nuisances, I would say, rather than serious risk of harm to self or others. Remember, physical restraints worsen delirium. They cause persistent delirium. They cause other harms, always problematic. These are not good, should be avoided at all costs. When do you use medications? I want you to think about medications in the behavioral management of delirium as chemical restraints, because these medications do not treat delirium. They do not necessarily modify the length or the duration of delirium, and so they are strictly symptomatic. So what are appropriate indications? I have a pretty high bar for starting medications, specifically low-dose antipsychotic medications. I would say the two appropriate indications would be an imminent risk of harm to a patient's self or another person, or if they're experiencing distressing psychoses in the context of delirium. Please use an abundance of caution in your patient with Parkinsonism, as many antipsychotic medications will worsen Parkinsonism, cause other extrapyramidal symptoms, and they are at risk for neuroleptic malignant syndrome as well. We favor quetiapine in these situations due to the lower risk of extrapyramidal symptoms. Alcohol withdrawal is an exception because benzodiazepines are actually life-saving treatment there, and so low-dose antipsychotics are not the way to go in a patient with alcohol withdrawal. Keep in mind the risk of neuroleptic malignant syndrome, and keep in mind the risk of torsade de pointe with patients with prolonged QT, and more could be said there, but I'll leave it there. What is the agent of choice? I recognize that healthcare is kind of local and cultural, and every institution will have their own different flavors and preferences. And I think the fact that we all choose something different probably speaks to the fact that there's a bit of an absence of evidence here. My interpretation of the literature, and again, we could debate this and argue over this, but this is not perfect. This is art, not science. I advocate for using low-dose haloperidol. And the reason being is that when we look at low-dose haloperidol versus other atypical antipsychotics, there does seem to be a shorter duration of delirium from the literature. Now, the magic number is 2 milligrams in 24 hours. The reason being is that at this dose, haloperidol is much less sedating than other antipsychotic medications if you're under 2 milligrams in 24 hours. So it has a very narrow therapeutic range. Once you start ordering more than 2 milligrams in 24 hours, then it's probably a wash, and actually probably the risk of haloperidol is much worse than other atypicals. So when I see dosages of 2 to 5 milligrams of haloperidol ordered, I mean, it scares me because all of a sudden we're running into some very serious risks of these medications. If you're looking at something more standing because the patient has distressing psychosis, low-dose risperidone is a good choice. Again, look at these geriatric dosing range, 0.125 or 0.25 milligrams daily or BID, quetiapine, 12.5 milligrams or 25 milligrams as a starting dose. So again, be mindful of your dosing ranges. If there's contraindications to any of these medications, like your patient has Parkinsonism, for example, consider trazodone, 25 milligrams, BID, maybe even QID. And in rare instances, again, in your patient who have Parkinson's disease, this might be the one and only time I suggest using a low-dose benzodiazepine for severe, severe agitation. But you'd have to push me pretty hard to start that. What are the principles of using these medications? Start low, go slow, right? Make sure you've exhausted non-medication strategies. It's important to discuss the risks and benefits. We know that there's black box warnings for antipsychotic medications in patients with dementia. Patients with dementia are at the highest risk of developing delirium. Once you introduce an antipsychotic medication, the patients are then incurring the 1.5 to 1.7 times risk of sudden cardiac death of using antipsychotics. That should be discussed. That's a matter of consent with the care partners. Use the lowest dose for the shortest length of time possible. Once the delirium clears and the behavior's clear, we need to get people off of these drugs as quickly as possible. And those are some of the general principles. Okay, this is our last section. We're coming to a close. We should have lots of time for Q&A. This is a question I deal with all the time in counseling families. What happens to people once we've identified and treated all the reversible precipitants of their delirium? Everyone wants to know, how long is this going to last? How long is this going to take to clear? This has implications for our discharge planning. Where do people stay to resolve, in the healthcare system to wait for their delirium to resolve? So having some anchors here will help guide our care. I refer you to one study out of the UK. Okay, so this is the numbers representative of one study. These are not hard and fast numbers. They may not perfectly apply to our care settings, but in a general way, these numbers help us. In this study, they observed 1,500 patients who were delirious in hospital, and they followed them at 4 time points. And they took a cross section and said, how many patients were still delirious at each of these 4 time points after their delirium in hospital? When they were discharged, 45% of patients were still delirious. At 1 month, 33%. At 3 months, 26%. And at 6 months, 21% of patients still had lingering symptoms of delirium. So what do we do with that? What does that mean? Okay, so the best way I can explain it, and the way I try to explain it in my conversations with patients and with families, is that once we've identified and treated all of the known reversible causes, I usually start the clock for about 2 weeks. And I'll say something to the effect of most patients will get better from their delirium within approximately a 2-week period. But I also say, but there's a risk somewhere in the neighborhood of 20% or so of patients who can have lingering symptoms of delirium for up to 6 months. And I say, I don't have a crystal ball today. I don't know which camp you're going to fall into, but this is the possibility. This 6-month window has all sorts of problems, right? It's a problem for us as geriatricians because oftentimes referring providers will say, well, can you diagnose them with dementia now? Is this the new baseline? And we're going, well, we don't know. The delirium could last 6 months. This has a problem for discharge planners who are saying, so you're saying there's a chance they could potentially get better 6 months from now? So where do I put them? Where do they fit in the system? Do they go to complex care? Do they go to transitional care? Do we send them to long-term care for 6 months and then maybe they get discharged from there? Well, that's unthinkable. So again, this is a very tricky aspect of delirium care. And it's not strictly answered by the cognition question. We have to look at patients, social supports, their financial means, their functional abilities, and all these factors kind of weigh in on what happens to these patients. The message here, though, is delirium is not always reversible, right? I think we do a disservice when we teach delirium as a reversible condition. I call it a potentially reversible condition. And again, it could take a very long time to clear. This is the idea of persistent delirium. There's very often times where I'll see a patient in the hospital and the team has done an incredible job. They've looked at every possible precipitating cause. And all I come in there to say is, give it time. Give it time. You've done an excellent job. We are in a state of persistent delirium. What are the risk factors for persistent delirium? Physical restraints, underlying dementia, functional impairment, sensory impairment, multicomplexity. So delirium is potentially reversible. That's one message. And don't be discouraged if you're seeing it take a long, long time to clear. We started with this, but just by way of reminder, over a 2-year period, individuals after their first episode of delirium are at increased risk of dying, relative risk of 2, increased risk of long-term care placement, relative risk 2.5, and a 12 times increased risk of dementia over the 2-year period after their first episode of delirium. It's potentially reversible, not necessarily reversible. Delirium is associated with future cognitive impairment. I'll finish with the end of the case, and then I'll open it up for questions. So again, remember, a well-meaning but unfortunately incorrect member of the healthcare team told this daughter, your mom has severe dementia. The daughter said, this is not my mom. So it was not severe dementia. It was delirium. And so I brought her back to my clinic at 6 months to reassess her cognition. Her delirium had in fact cleared by that point, but she had had a stepwise decline in her cognition and she had had persistent cognitive deficits since her hospitalization. Unfortunately, she lost one or more of her instrumental activities of daily living, her ability to do those things based on her cognitive decline. And I made a formal diagnosis of dementia at that point, and the family was actively exploring a more supportive living environment. So Delirium is a medical emergency. It's associated with many bad outcomes, but I want to leave you on an upbeat note. I want to reinforce that message about the HELP program. 30 to 40% of hospital-acquired delirium is preventable with non-medication strategies. And I think we have to figure out ways collectively to own those strategies to avoid these bad outcomes for our older adults. And with that, a couple things to mention. So deliriumhelp.ca has a caregiver patient-focused education tool. This is put out by Dr. Anthony Levinson and his group. And so I'd refer you to that. It's a 15-minute module. I've been through it myself. It's excellent. And then the Canadian Geriatric Psychiatry online program has some learning modules with delirium and other topics for your interest as well. That's also put out by Dr. Anthony Levinson and his group. And so I'll plug those for you as resources at your disposal. And I'll also point you towards the RGP Foundations course, which has lots of talks, short 20-minute talks, which is a course you can take that's certificate driven that has delirium and other topics like this. And so hopefully at the end of this talk, you feel more able to recognize delirium quickly, confidently, and accurately. You're aware of the ways to prevent delirium, and you now have an approach to identifying and treating and managing delirium in your patients. So thank you very much for your attention, and over to questions.
Thanks so much, Sam. That was just excellent and fascinating. I really refer a lot of my patients and the residents to the persistent delirium chart that you shared with us. I can't tell you how important that is to share that with both the teams and the family. When you hear that 45% of our patients are delirious on discharge, and we're sending people home on 3 times a day dosing who live alone. And then I see Sam nodding. Nobody's surprised when they come back to hospital that they really are not taking those medications. I think the other caveat is a lot of these patients do present quite well, but their executive functioning, that front part of the brain, when they're still, that subacute delirium is just not firing. Have you seen that, Sam?
Oh, absolutely. And the most common thing I'll get is, oh, well, they're alert and oriented times 3, they're good to go. And I go, oh, have you ever asked a question of attention? And then you go in the room and they can't do the months of the year or the days of the week backwards to save their life. And or you get them to draw a clock and it just exposes that they're not able to plan or organize or multitask. And so the idea that they're going to go home and get meals for themselves or take their medications on time is very unrealistic. Yeah, completely agree. I think it is one of those secrets. I don't know how it doesn't get communicated earlier on in people's medical formation, that delirium is persistent and can stick around a very, very long time.
Yeah, and I think that's a really key. I love Sam's key takeaways, practice takeaways. That's a key takeaway for discharge planners who are attending, for hospital administrators, to remember that these people are going home, they're moving, but there still is some planning that needs to happen. The other thing, and maybe you can comment, Sam, is we've been using the anticholinergic burden scale on a lot of these patients. And just olanzapine or Seroquel will put people at 3, which means that you're high risk for precipitating delirium. Any thoughts? Because we've seen a lot of Seroquel in practice being used for sleep, for wandering at night. Any thoughts on this? And then I'll go to the questions that have been posed.
Yeah, those are great comments, Alex. I personally, I do check the anticholinergic burden scale, but I don't use it a ton clinically because of those things. Because sometimes, these are necessary medications for certain indications where you're kind of trying to balance risks and benefits, right? And so we could do a whole other session on sleep aids and whether there's such a thing as a sleep aid and the benefits and risks. and especially with the new orexin inhibitors, like how those factor into those discussions. So, yeah, there's so many ways I could take that question. It's hard to know where to start, but
We'll move to we'll have you back for sleep.
okay. Yeah, yeah. I think with the anticholinergic, I think these are one of those multifactorial causes, right? It's rare. I think it's rare that we see the anticholinergic med be the fundamental precipitant, but it is another one of these factors. And as our audience may know, the medications we use to treat dementia are procholinergic. And so anything you're doing that's anticholinergic is going to work against your memory center and what we're trying to do to improve cognition. And so again, you have to think about it as like a damper. And so we want to minimize anticholinergic medications because we know it's going to impact memory. And so even if it's not the main precipitant, we want to wean people down on these drugs when they come in because it's going to worsen the delirium.
That's a great way of explaining things. So I'll go now to our questions. From Petronella, Schwartz comments that nutrition is challenging. We need more staff or volunteers in the hospital. Um, is it worth using an assessment screening tool?
I, Wonderful comment. I think I so appreciate the concern around staffing, and I think all of us would feel that way in every domain and discipline where we are right now. And so I just empathize. In terms of a validated screening tool, I'd actually refer to some of my other colleagues who might be able to speak to these things better. I I learned nutritional status, through an eyeball test. And that's really where it starts for me, if I'm being honest, is am I seeing sarcopenia? And am I seeing subcutaneous tissue loss? And so, if nothing else, we have to at least comment on it and note it in our physical assessments as a first step. I do think screening tools can be useful, but I'm also very mindful of the tension of adding one more thing to the workflow of our busy frontline staff. And so it is very tricky, and we know that scales don't always get done effectively or efficiently. So, it's this fine line. So I don't feel I'm either equipped or in a position to fully recommend one or but I do think we have to pay very close attention to it, and particularly pay attention to the risk of sarcopenia and protein malnutrition in our older patients, because that's going to lead to frailty. It's going to lead to further iatrogenic cascades and deconditioning in hospital and affect their rehabilitation potential and their mobility. So yeah, if I'm going to put an emphasis on one area of nutrition that's low-hanging fruit, it's optimizing protein intake.
So as you were doing that, Sam, you triggered me to Google. There is a malnutrition screening tool recommended by a consensus group in Canada. Very simple. Have you lost weight without trying? Have you been eating poorly? And it's very easy to score. And so I think that the other caveat Sam mentioned is examining the patient, when we see them is really key. Another question is opioids are associated with delirium post-hip fracture. What are your thoughts on pain management? There's some concern opioids may be stopped too early, or should, along with the scheduled Tylenol.
Yeah, great questions. Our delirium case this morning had to do with opioids and delirium. And myself and my learner were going back and forth on, was it the pain causing the delirium or was it the opioid causing the delirium? And it was really, really difficult to tease out, to be honest with you. So just acknowledge the tension there. I think I would follow the World Health Organization kind of guidelines and say it starts with standing acetaminophen. Generally in older adults. Alex, please feel free to disagree, but I'm generally recommending up to 3 grams or 3,000 milligrams of standing acetaminophen in a 24-hour period would be the backbone. And then we are trying to minimize or avoid opioid use as much as possible. But I understand that there has to be a role for these in post-op settings and in different situations. If I'm going to pick the lesser of evils, I would, again, feel free to disagree, but I would lean towards hydromorphone as it's less renally cleared in our patients with rising creatinine with older age. And again, I would be very specific about the dosages that we're talking about. And so, people might laugh at me as to where I would start with hydromorphone dosing, but I would go as low as 0.25 or zero point 0.5 milligrams, and I would dose it, every 4 hours or every 6 hours as needed to minimize how much is going in. You can obviously go up from there, but I would not recommend starting at 1 milligram or 2 milligrams every 4 hours as needed. The other thing to keep in mind with hydromorphone is that when you use a non-oral route, the effectiveness doubles. Okay. And so if you're giving 0.5 of IV, it's like 1 milligram of PO, and that's often not picked up on. So those would be a couple little things I would think about, but I just appreciate the dilemma. Obviously, the goal would be to minimize opioid use as much as possible.
And I would agree with that. And I think our physiotherapist can be an occupational therapist, can really help us because sometimes people will be concerned about pain, but when they're mobilizing, they're actually not in pain. The other thing is to remember with a fall, energy is often transmitted into the spine as well. And sometimes we've missed the spine fractures. So think about, is there something else going on in the patient as well? So totally agree. Um, Marie, our consult team nurse here at the Gervincy wants us to point out that there are delirium order sets at Hamilton Health Sciences. I think we'll be updating them in the near future. So many of the hospitals may have them, so look at those. Another question is there is a delirium strategy from one of our nurse practitioners, Carrie, through Ontario Health, called DASH campaign, and it's available to all the hospitals. I would say most of it, when I reviewed the tools, is everything that Sam's highlighted, but it's another resource. Just to reiterate, this is going to be available on the JERIS YouTube channel with the presentation. Another question from Kaylin Campbell. To clarify, with persistent delirium, will CAM still be positive or will there just be persistent cognitive changes? Thanking you for the excellent presentation.
That's a fantastic question. This is where, yeah, we get into the weeds a little bit. So I would argue that there are times where patients who have persistent delirium are CAM negative. And I would call that subsyndromal delirium. So they're not syndromically positive, but they're still fluctuating, inattentive, but may not be disorganized with an altered level of consciousness. I know colleagues who would disagree with me on that, but I would argue, yes, that you can be CAM negative and still have features of what we call subsyndromal persistent delirium. Alex, feel free to weigh in on that if you.
No, 100%. And I think increasingly there was a great article in Nature showing the whole inflammatory cascade delirium causes. And so I think if we really realize that we're allowing delirium, we're not preventing delirium, and it's starting this whole inflammatory cascade that can result in our patients having sliding down, becoming diagnosed with dementia, or just becoming that much worse. I think as we go in the future, we're going to hear more about the whole inflammatory cascade. So agree with what you're saying. There's also the question about, oh, this is a good one from Carrie. What about doing the MOCA? When should you do the MOCA?
Great question. Thank you, Carrie. So, again, there's a bit of art to this. And so, Alex, we can have a dialogue about this. So, we have to remember how the MOCA was validated. And so the original studies were done, in the outpatient setting when patients were obviously not delirious and not experiencing an acute health crisis. And so it gets done all the time. I always take those MOCAs with a significant grain of salt. I would not consider them valid. And even the utility, I might be stepping into hot water here, but the utility of a MOCA on the inpatient side now is questionable in certain circumstances. Now, if you've been stable for a long, long time, and we need a diagnostic tool or we want some insight into your cognition, it can be very helpful, and I do use it, but not useful for the identification of delirium, not useful for monitoring resolution of delirium. And so I would generally recommend avoiding it, similar to the MMSE. And that's where I would use validated screening tools like the UB2, like the CAM, the 4AT, and there's other tools like that that are available for tracking delirium specifically.
Yeah, and I'm going to say we have a cognitive workshop led by Dr. Dave Cowan and the RGP that I encourage folks to attend. And that's as well, the MOCA hasn't been validated in acute care. And so I think we're labeling people prematurely. Another comment is, why don't hospitals invest more in the health program like programs? We know the evidence. How do we advocate for hospitals to invest? Any thoughts on that, Sam?
So if you're a health leader on the call, please know that there's great business cases in the literature for the HELP program. We know with an investment in the neighborhood of $250,000 per hospital, so that's hiring usually a hospital elder life specialist and a recreation therapist, we can save the hospital somewhere in the neighborhood of $10 to $20 million per year. So the business case is settled. There's no argument that the HELP program works and that the HELP program saves the hospital money. And so it's just a matter of people believing in it. And I don't understand the psychology of humans well enough to know why we don't make these decisions, and nor am I equipped to understand the complexity of hospital administration and budgets to make these decisions. And so I just present the facts, but I am strongly in favor, and I completely agree with the comment. But obviously, we're in a very budget constrained time and things are very tense. And so it's hard to see the value of this. So we press on and we plod and we advocate, but it does work and it saves the hospital and the health system lots and lots of money.
I mean, it was a very interesting. There was a delirium presentation by Jerry Medrisk yesterday. And, a very interesting comment is if we could identify people who are at risk for delirium and emerge, maybe they get expedited to the ward and they're not left in the hallway where we know where the cascade is going. And the cost is, the business case is there, as Sam says. Um, the next question, lots of great questions here. People are obviously passionate about the topic. Alex Kirkovic from the Health Program at Hamilton Health Sciences asks, thanks you for the great presentation. Key feature of delirium is attention deficit. However, patients with dementia also experience attention deficit. How would you approach in patients with dementia?
Such a great question. That's someone who's very experienced with delirium who asked that question. So what surprises people? Because my trainees will often say, months of the year backwards really hard. Like I struggled with that. And I'll tell them, and you can, I practice this. I practice both in the outpatient and the inpatient setting. I will tell you, my patients with moderate dementia, when they are not delirious, can tell you the months of the year backwards. So you have to have pretty advanced dementia to not be able to do the months of the year backwards. That surprises people. So I think it is a good question, and I think it holds up. Once you have moderately severe dementia or worse, I grant you the domain of attention becomes so impacted that asking these sorts of questions, rolled backwards, serial sevens, 5-digit span, becomes very futile. In this case, we're going to lean more heavily on the history, and we're going to ask the care partners and the family, is this the baseline, or is this person more confused than their usual self? And we're going to observe for fluctuations. The attentiveness will come out in different ways, right? It will be falling asleep while they're talking to you, picking at the bed sheets, jumping, or, be hyper vigilant to sounds. And so you have to use your powers of deduction and observation more so than formal tests of attention.
Thanks, Sam. This is an interesting question from Samantha. What about driving post-delirium? What's your approach?
Wow, that's a fantastic question. I think if you ask five different geriatricians, you probably get five different answers. So I'll tell you what I do, but don't take this as gospel. And Alex, again, as always, please feel free to disagree with me. Wow. Um, so if you read the MTO form, um, and if you review the CMA driving guidelines, okay, what do we know? So the CMA driving guidelines does not indicate that delirium in and of itself is a mandatory reportable condition. And the CMA driving guidelines would also say that mild dementia may not be mandatory reportable if you don't meet other certain criteria, but moderate dementia is an absolute contraindication to driving. So where does that leave us? I have to go back to what were they like before the delirium, okay? And I'm going to do my risk assessment based on collateral of what was going on cognitively and functionally before the onset of the delirium, and I'm going to use that to adjust my risk of the situation. In areas of uncertainty where I'm not sure, I will bring them back to my clinic and personally follow up on that once I think the delirium's resolved. And in those cases, I may or may not contract with them to not drive as the delirium is resolving. If they were very highly functioning beforehand and we see the delirium improve in hospital to such an extent that we feel pretty good, we may not do anything and they may just return to normal life. And if there's serious concerns about cognitive and functional decline before the delirium and they were still driving and then they become delirious, I may report them in hospital based on the pre-concerns. Now, patients can always challenge those assessments and go for an occupational therapy ministry approved driving assessment. And so that's their prerogative. But I have to make the decision based on my own assessment of risk in this situation. So it's patient specific.
And I'd 100% agree. And I think, Sam, you touched on a key point is you need to get the past function. And I know in most of the patients we've been asked to see is we haven't had that clear story. What were they like before this happened? And that's a critical piece. So really, there's more questions than we've been able to answer. We'll do our best to send replies. And so I'd like to thank everybody for joining us during your busy lunch hours. And thank you again to Dr. Sam for sharing his pearls with us. And I hope you can take them back to your own local communities. Thanks again and have a great rest of the day, everybody. Take care.